Okay, so this video is to try and help people in EMT classes learn how to create a patient narrative, which really is an essential EMT skill. Now, when I say patient narrative, what I really mean is not only the documentation of your patient experience, your patient encounter, but I also really mean almost the whole way you approach a patient, how you're going to interact with that patient, interview that patient. And so it's more than just a paragraph you're going to write on a piece of paper. It's really going to help you figure out how to treat that patient, and it's going to provide you the opportunity to provide a much better handoff to the emergency department, which can actually ultimately uh, save a life or help the ED treat a patient better as well. So traditionally, this isn't a big thing in EMT classes. Everybody has a different way of creating a patient narrative. Everyone has a different way of approaching patients. And to be honest, each patient's a little unique. Each time you see a patient, something else is going on, something different is going on. So, each patient is unique, each EMT is unique. And as you go through your education, you're going to find a lot of people say, no, don't do that, do this. Don't do this, do that. So honestly, take what I say with a grain of salt, take whatever else says with a grain of salt. And as you get better, you're going to learn how to do your own thing. You're going to mold your patient narrative. You're going to mold your patient experiences. And of course, some departments actually have a set standard patient narrative that they want you to use. Oh, you always have to do it this way, that sort of thing. So traditionally, there's a few different ways to do it. One's called CHAT, which is your chief complaint, history, assessment, and treatment, or transport. Or you have SOAP, subjective, objective, assessment, and then plan. And that's more of an in-hospital thing, but we're going to use that today. And we're going to kind of mix these a little bit. And the next one is chronological order, which is a step-by-step explanation, which is honestly messy. It's not a great way to do things. You're going to forget what happened. Keep in mind that the main idea is that you're going to have to get a patient, work through what's going on, elicit all these questions and responses that you need to treat them, and also get all the information you need to give report to the nurse. So chronological order, it may not help you. First of all, your report is going to be horrible to the ED. And second of all, you're just going to leave things out, forget things, past medical history, that sort of thing. And then finally, sample. Some people would want to put sample as a narrative, but keep in mind that sample is just a way of asking questions. It's not really a narrative fashion. All right, so overall, your assessment goal is that you need to be able to pull from that patient all the information you need to treat them, to figure out what's going on, treat them, but you also need to get all the information that you need so that you can provide great continuation of care in the ED. And by continuation of care, I mean that when you get to the ED, you should be able to provide the emergency department enough information that they don't have to go back and recheck your steps. Because a lot of times, if you forget to tell them one thing, they're either going to miss it or they're going to have to go order another test to discover the exact same thing you could have told them. Oh yeah, he was vomiting. If you forget to tell me he's vomiting, that can be a major potential for a head bleed, clotting, some sort of cardiac arrhythmia, anything. So you really need to make sure that even the smallest things are being provided to them. And so part of that is your documentation, but part of it is your patient handoff as well. So part of the goal of the assessment is to be able to get the information to treat the patient, but then it's also to continue the treatment after you're done. So what should I be doing? I don't really understand what's going on. Basically, what all I'm saying is this is a great way, this is an easy way. I just want to give an example of the steps that I take with a patient when I first encounter them, and then also the steps that I take when I write up my encounter. So every time, obviously, I'm going to need to know a chief complaint, age, sex, ethnicity, demographic information. I'm going to get a sample history. If there's pain, I'm going to get OP, QRST, that sort of thing. So there are some things you're going to do every single time, and this kind of falls in line with the chat or the SOAP note, more with the chat note, which was chief complaint, history, assessment, and treatment. And then situationally dependent, though, there's other things you're going to want to get. You're going to want to get a further medical history if someone has maybe a genetic problem or possibly a genetic problem. You're going to want to have a more in-depth social history if there's a lot of things going on at home, if maybe there's a depression, that sort of thing. You really need to know what's going on. Maybe if it's a young mother or if it's a child who's been taken out of the home. that sort of thing. So sometimes you're going to want to have a more in-depth social history. And other times it's just signs and symptoms dependent. So if you're having abdominal pain, what else do I want to know? What other questions am I going to ask? So if you think about it, abdominal pain could be a lot of different things. You could have maybe appendicitis, or even a acute traumatic thing. It could be a kidney stone. So there's different problems, but you also need to know what's going on besides that. And something like abdominal pain, you're going to want to ask a little bit more in-depth questions. Well, what did you eat? When was the last time you defecated? What are you on? Blood thinners? What other medications are you on? Is there a history of abdominal pain in your family? What kind of medical history is there? That sort of thing. So it can really lead you down a path. So what I'm really trying to say is that there are, chat and those kinds of things really help in basic things, but be aware that each situation you're going to want to try and elicit these kind of weird different things that you may need to ask. So for an abdominal pain example, if I'm just going to go follow the normal history, I may not figure out that there's a family history of aortic dissections or Marfan syndrome, something like that, which might cause an aortic aneurysm, and I might miss that. So, and it's not up to the EMS to treat an aortic aneurysm, but it is a great way to increase the treatment of your patient by starting to ask more questions, kind of probe around a little bit more, and when you get to the ED, you're going to provide a much better continuation of care for that patient. Okay, and then goal 2, as you get better, you should be able to provide a short, concise patient narrative to the triage nurse. And you shouldn't have to look at your run report, oh, I don't know, I forgot. You shouldn't have to ask the patient, hey, do you have diabetes or not? You should be able to say, yes, this is a 34-year-old female complaining of shortness of breath with a history of asthma. We gave her albuterol treatment en route. Her asthma or her breathing improved, and she's now on oxygen. And you can even launch into everything else you found out. She has a history of allergies to grass and blah blah blah. She has her inhaler here. She's on this and this medication for her allergies, and on and on and on. So this isn't a hard thing, but at first it's going to be hard for you to develop. Well, what do I really need to say? What's pertinent information that I need to provide? But as you go, you'll learn how to provide that. So what we're going to do is we're going to do kind of like a hybrid assessment. So what I said earlier is chat and SOAP. And so I want to talk about these for a little bit more before we keep going. So SOAP note is subjective, objective, assessment, and plan. Chat is chief complaint, history, assessment, and treatment. Okay, so basically these are the same. AT, assessment and treatment, and assessment and plan. Those two are the same. So over here is a different way to organize things, a chief complaint and a history. That's really breaking it down too simply. Here we have subjective and objective. So subjective, think of subjective as what the patient says. And think of objective as what you see. And this is going to provide you a much better way to, first of all, assess the patient, but also a better way to document that assessment and to explain that assessment and treatment. Okay, so let's talk a little bit more about this. And keep in mind that when I say patient narrative, really we're talking about the documentation, but I'm also talking about how I approach this patient. So let's say you're dispatched for a lady who has fallen in her residence. Help, help, I can't get up. So okay, so we get there, and you're going to go through your trauma assessment and all that, yada yada. Long story short, we have, let's say, a 76-year-old female, Caucasian, found down with a compound tip fib. Okay? so here's our chief complaint. We have a little bit of demographic information here. Okay, so this is how we're going to initially start. And of course, you go through your basic, does it hurt here, does it hurt there, do I have distal pulses? I'm not saying anything about that right now. All I'm saying is a little bit more further assessment than what you're taught in your class, a little bit more than the basic sample history sort of thing. Okay, so let's say you get her on your spine board, you wrap up her leg, get her in the truck, that sort of thing. So overall, you just did your job. Everything's great. But we're going to do a little bit more of an assessment. So objectively, let's see what happened. So objectively, tell me what happened. You want to ask the patient, tell me. Don't put words in her mouth. Say, hey, tell me what happened. Tell me more about your fall. And she says, I don't really remember. I don't know. Okay, so right there we're wondering about a level of consciousness or loss of consciousness. Did she lose consciousness? She doesn't really remember what she hit. She doesn't remember falling, that sort of thing. So we're in an LOC. And so she says, no, I don't remember it. I don't know. So we're not really sure. She might have lost consciousness, so maybe a positive loss of consciousness. Okay, so right there, our objective assessment is kind of bringing us more in something. Because obviously our chief complaint is a compound tib-fib fracture, but what caused the chief complaint? So maybe loss of consciousness. So what's going to cause loss of consciousness? So heart, right? We got to pump oxygen into the brain. Oxygen, obviously. Maybe if she's on home oxygen, does she have COPD, something like that? Maybe a vessel problem or a pipe problem. So maybe does she have a clot that prevented her from consciousness? And then of course a volume problem. The pipes can be great, but if there's no water or blood to push, then there's a problem. Okay, so we had our basic assessment that every EMT would find. You're going to find your chief complaint. The loss of consciousness leads us in a different direction. We're wondering now, this is the chief complaint that she had, but what else are we worried about? And we have one of these things that we might also be worried about. Okay, so now that we have a subjective assessment, we talked to her, we asked her what's going on. We want an objective assessment. So this is going to include your vitals, your physical assessment, and then if there's a bystander, which there's not in this case, but any sort of bystanders, that sort of thing, general appearance. Now you could put her past medical history on objective or subjective. It really depends on how you got the information. I'd probably put it under subjective, but we'll put it here just to talk about it. And then maybe allergies and meds, of course, these would be in subjective as well, but we'll talk about it here. Okay, so subjectively, we let her talk to us. We didn't put words in her mouth. She told us, yes, I don't really remember it. I don't really know what happened. Okay, and then, of course, we probably got past medical history from her through the subjective as well. So, what past medical problems through our sample history. And so, in our mind, loss of consciousness, we're thinking oxygen, vessels, heart, volume problems. Maybe the medication, we're going to get some information. So let's say she's on a beta blocker. That's no fun. Let's say she's on Coumadin for AFib. She is on Zyrtec or something for her allergies. And then she's on, let's say she's on a diuretic for her hypertension. Okay, so right now we have a little bit more explanation. This is, I guess, through subjective as well. So AFib, so we're worried about heart there, right? But that's also vessels, right? Because AFib can cause clots. So clots from AFib can block vessels. But we can put it under heart too. Because also, if there's not good contractility, if your heart's not able to pump, then that can be caused by AFib. If your AFib is really bad, she stood up too fast, something like that, The AFib could be a problem there. Of course, volume could be a problem too. She's on a diuretic, which is going to make you urinate a lot more. You're going to drop volume. So that's concerning. And then, of course, the Coumadin, we're also worried about hypocoagulability. So maybe her blood's decreased coagulation. The reason you're on Coumadin is to prevent clots. And so the problem is that Coumadin has a very narrow range of use. And a lot of times people are also not on their Coumadin. Sometimes they don't take it. So we're about clots. We're also worried about hypercoagulability if she's off her Coumadin, that sort of thing as well. So, okay, and then objective, of course, vital signs. We're going to look at her vitals. We can even do orthostatic blood pressures to see about volume. Our physical assessment is going to tell us if there's any stroke-like symptoms for vessels. And then, of course, bystanders, that sort of thing. So we used our subjective as a start point, our sample history, that sort of thing, and then the objective came in, and we started to kind of go down paths. So we had different paths we started going down because of what we saw and what the patient was telling us. So right now, we know she has a compound TID fib. Every EMS crew in the world got that. Congratulations. But what we're finding through a little bit better assessment is, hey, there's a possible loss of consciousness. We think there might be a volume problem, a heart problem, or a vessel problem. Our physical assessment shows no stroke-like symptoms. She says she's on her Coumadin. She says she takes it every day. She doesn't seem like she doesn't take it every day. She seems pretty reliable. So we're not too worried about clots. She's on oxygen. She doesn't have any lung problems besides allergies with Zyrtec. So we're not super worried about an oxygen problem. Maybe her lungs sound good, so that's going to clear her lungs. So we're still worried about her heart with her AFib, and we're a BLS unit, so we can't do an EKG. Not that it would really help us that much. And then a volume problem, orthostatics, because of her diuretic. All right. And then the next part is our assessment and plan. So, of course, our assessment is she has a TID-fib compound fracture, and she fell, so we're going to spine board her and fix her compound TID-fib. And then our plan is to continue to monitor for vital changes and possible cardiac or volume changes. And then, of course, we're going to go down any other paths we see as well, too. All right. And if you notice here the chat note versus the SOAP note, the chat is really just a little bit too small. All it is she complaint in history. It really doesn't provide you the reminder to kind of go out of your way to find other things going on. Okay, so we have kind of a differential diagnosis. And I use the word diagnosis here kind of loosely. This isn't really a diagnosis. We're just kind of trying to find a differential explanation. Let's call it an explanation for what's going on. As EMTs, you don't diagnose. I really want to stay away from the word diagnose, but it does kind of make sense to think of it that way. So okay, so we have a fractured TID-fib. Orthostatic hypotension is our volume, our diuretic problem. Maybe an AFib related, and then the clots maybe in the CNS could that have caused it. You can also have clots that happen and then they go away, that sort of thing. And they were also concerned about loss of blood. It's a compound open fracture. And she's on Coumadin, which means she's going to bleed a lot. Or at least we think she's on Coumadin. And so we are worried about Coumadin levels. Like I said, Coumadin is kind of a tricky drug. And if she's not well regulated, she could have too high levels or too low levels. And if it's too low, she's going to be clotting. And if it's too high, she's going to have GI bleeding. And of course, she's had traumatic bleeding, so she's going to have increased bleeding through trauma too. So again, it's not really a differential diagnosis. It's more of just, let's look at the body systems of what's going on here and try and explain things a little bit further than what we're really presented with. Because if we can try and go one step further, we might be able to do something a little extra. For example, the loss of blood at the Coumadin level, the extra bleeding. Obviously, we're going to provide a little bit more oxygen. If we were an ALS unit, we'd be putting a saline bag in, or I guess maybe a ringer bag in, that sort of thing. So it's always good to keep thinking and to keep kind of following down these paths. Okay, and so the first part of what we talked about today was our assessment, our patient narrative, our patient narrative can help our patient assessment and really pull together all the different loose strings of what's going on with this patient. If we kind of keep talking, keep trying to figure out what body system we're looking at, what's the pathology behind this, what's the epidemiology behind this, it really helps you try and treat your patient. So that's the first part. The second part is when I get to the ED with this patient, I need to provide a concise report to the nurse to explain what I did for this patient and what's going on with them. Because the whole idea is that this nurse didn't get a dispatch. This nurse wasn't on scene. You have to paint a picture for them of what you saw, what you did, and what the patient looks like. They can look at the patient, but you've seen the patient longer, you know what's going on, that sort of thing. So the idea with the patient presentation is you need to paint the perfect picture of this patient so that they can continue care for this patient, and that they can understand what's happened to the patient so far. Because all they have is a patient. They don't know that they don't know there's a compound fracture underneath all that gauze. They don't know that, yes, there was a loss of consciousness, that sort of thing. And yeah, it is in your written report, but to be honest, no one reads EMS written reports in the ER. So this is your one time to tell them something. Okay, so starting out a patient presentation is your chief complaint and demographics. So I think we said it was a 76-year-old female, Caucasian woman, and she has a compound tib-fib fracture. We'll call it the left leg. So we have our demographics here. She's a female, 76-year-old Caucasian with a compound tib-fib fracture on the left. Don't use this shorthand on your actual report. Just write it out. Okay, so that's our very first sentence. This is a 76-year-old female Caucasian woman. We found her with a tib-fib fracture of her left leg. And the pertinent history, so we're going to go right into it. She had a loss of consciousness leading to a fall, which caused her tib-fib fracture. And she's, she had a history of AFib, and is on Coumadin, which she takes. Daily. Okay. So there's our pertinent history. So this really gives a nice, concise explanation of what happened. It's not just, oh yeah, we found her, she broke her leg. This is a 76-year-old female with a compound tib-fib fracture. She had a loss of consciousness, which caused her to fall in her home and caused her a compound fracture. She does have a history of AFib and is on Coumadin, which she does state she takes every day. So then this is a little bit different than in hospital. You see a lot of med students or physicians giving the patient presentation. And if that's the case, then you would probably add a lot more right here. So you give a little bit better, a little more in-depth. So don't be afraid to add a little bit more in here. But just keep in mind that this is for a triage nurse or the nurse who's taking over this patient. We really want to be nice and concise. So we want this to be really quick. Once they lose interest, they're not going to listen anymore. They got a bunch of other crap going on. Okay, so then we're going to give the treatment provided, spine board, and stabilization. So we put her on the spine board and stabilized her fracture, and she has good pulses in the extremity, good color, no further complaints. And then if you have time, if they're still listening, and I know how triage nurses can be, you want to give a further assessment or a further history. So this is where we're going to put something about, we're really honestly not going to mention her Zyrtec ever. That doesn't matter. But maybe her, we're going to her diuretics are definitely going to be mentioned here. And the hypertension will be here. Any other histories? Maybe previous falls, prior falls, family history, social history, anything that's pertinent at all. Any other medications that she's on. Of course, that's going to be listed on her. Zyrtec's going to be listed on her actual patient EMR. So anything else there, if you have time, if they're actually going to listen to you, feel free to add in there. Okay. So let's just go over it one more time. A basic patient presentation should be nice and concise and put a good picture in their mind of what the patient is going on with, what's going on with the patient, excuse me, and what you have done for the patient. And then a little bit more explanation of what's going on with them. So the goal is to really paint a picture of what's going on with the patient, possible tertiary causes, that sort of thing. So our chief complaints is a 76-year-old female, Caucasian. She has with a compound tib-fib fracture of her left leg. She had a loss of consciousness at her residence earlier this evening, which caused her to fall, which caused her to have her compound fracture. She does have a history of AFib and is on Coumadin, which she states she takes regularly. At her residence, we put her on a spine board and stabilized her fracture. She has good distal pulses, good color on her leg. She has no other complaints at this time. Her vitals are stable. Oh, she's still listening? Well, I guess I might as well give her a little bit more. She does take diuretics for hypertension, and she does have a history of 2 prior falls. No family history. She does live alone in her residence with a dog. So the last part about the living alone that's part of the social history. That can be a problem if they're going to try and send her home, that sort of thing. So. Okay, so overall what we've really done here is we've gone through how to take your patient assessment, take your trauma assessment or medical assessment, and step it up one more notch. And this is more than just a chat or a sample history, that sort of thing. You really want to look at the body systems, the organ systems behind the trauma, behind the medical problems, and really try and eke out a reason for what's going on. That sort of thing, and it's going to really lead your treatment better. So we're looking not really for a differential diagnosis, but we're looking for a better explanation and other possibilities. We don't want just one possibility. We can follow along with 2 or 3 possibilities if we need to. And the second part of what we've talked about today is providing a good patient presentation. This isn't just in the ED, honestly. If you're on scene with multiple units, you may have to give off a patient to somebody else to send in, and they need to know all the information on that patient. And so how we're going to do that is with a basic presentation model just like this. The chief complaint and demographics, the pertinent history, the acute history of what's going on, what treatment you provided, and then a further assessment. And as you go, you're going to get a lot better at this. It's going to seem awkward at first, but it really does help to get in the mindset of really practicing and doing this a lot, okay? So if you have any other suggestions, if you have a better way of going about this, leave a response, let me know. We can talk about it, and I'll do some follow-up videos on what other people are doing out there. If you have any questions about what's going on, or if you want more examples, if you want me to run through a few more patient presentations, I would love to. Just, put a response and let me know. All right, thanks, guys.